Okay, let's move on to this case. This is a 45-year-old logger, polytrauma, work-related, and one that I kind of got pulled in late. This is from just about 10 years ago, almost exactly. So this was early in my career. So I learned a lot since then, but I learned a lot from this case for sure. Jan, what do you think? This is all I have for injury films.
Yeah, I mean, I think this is a bad injury. Obviously, it's open, or it appears open at least, right?
We're going to say it was open. I actually don't think it was, but it seems like it had to have been.
Yeah, I mean, this is one where, you need to get it reduced, and then it's damage control in my hands for this, to try to minimize, further complications. As, one of my partners always says, DNI, do not infect. Because this is a high rate of complications. This is not only a bony injury, but a soft tissue injury. So I'm very pessimistic looking at this X-ray right now.
Yeah, me too.
This gets me out of bed.
Yeah. I was getting this mixed up with somebody else. This was an open injury, open laterally, as you might expect. Mm-hmm. You're going to cringe here in a second, Jan, just based off the comment you had from before. So just brace yourself, okay?
All right.
So it's polytrauma, right? So there's a bunch of other injuries. This is out in Oregon, so logging, which is can be high energy type of injuries. So a subtroch on the left, the right side, the ipsilateral side has a proximal tibia fracture, and the left side has a patella fracture. So this gets managed kind of in the middle of the night, has fixation of multiple fractures, and then a pretty aggressive debridement of this open fracture on the right. And so this is what I get, a text message I get with these pictures. So there you go. There's your staples. You can see where probably the traumatic wound was.
You're killing me.
Yeah. There's a drain, looks like. That's what I thought too. So now what? I have a CT scan showing a big void. This led to a couple questions from my perspective. One is, what do you do with an open talus fracture? We talked about how sometimes there's limited soft tissue attachments. When we talk about open fractures and management, one of the tenets of a debridement is removing anything that's devitalized bone. Do you approach the talus in the same way, Jan?
If there's pieces of cartilage on it, I try to save bone with cartilage on it. So that's the difference. It's different than like a tibia or femur when you have diaphyseal bone or metaphyseal bone. That's extra articular. So yes, I do. I do approach it differently. Obviously, if it's grossly contaminated or something, I may take it back for, a couple of washouts before trying to fix something.
Yeah, I agree. So now what? What do you think?
So if the bone is missing, I'm thinking about an antibiotic spacer and trying to fuse this.
Yeah. Would you?
So I'm curious where the bone is.
Yeah, I think it's in the bucket. Actually.
Yes. I mean, this would be an antibiotic spacer for me then. And this is like, for some people maybe on the line, like there's been a lot more recent, I would say, I don't know how good of literature, but there's at least promotion of like 3D printed taluses and so forth.
Yep.
They are contraindicated in open fractures.
Yep. Yeah. I think you have to really, you can't just jump to that. I don't think. I think you have to figure out some way to kind of manage it. Sometimes we've talked about this a little bit already, but non-reducible dislocations, that one of the questions that kind of comes out of this talk as well is, this one was open, so I think it was more reasonably reduced, but there's structures that can get in the way, and especially when you have a medial dislocation, things like, and maybe this is more pertinent to a subtalar dislocation, but you can get buttonholing of some of the capsule, interposition of the perineal tendons, things that can come up that prevent you or block you from getting it reduced. Not the case in this particular situation. So that's exactly what I did. I took him back and decided to wash him out and placed a antibiotic spacer in there just to hold it out. I think now I might put an X-Fix on this as well. I didn't at the time, but I think now at least, like a medially based X-Fix might have been reasonable in this case, just to try to hold that out to length a little bit. But I kept this in for several weeks. I think it might have even been 6 weeks. That might have been too long. And then I took him back and did an interpositional distraction arthrodesis, and I fused the subtalar joint. What do you think?
Yeah, I mean, it's interesting that you fuse the subtalar joint. I'm not against that, but they do talk about some revascularization when you do that.
Mm-hmm.
So I think this is a good, result. This is limb salvage.
Yeah.
Yeah. So like I said, it's damage control, limb salvage. So I think this looks, I mean, you're getting the job done, right? You're doing basically a double arthrodesis here.
Yeah. And, this is a big question that's come up. We actually just looked up, we don't have a huge series, but just submitted, and I think got accepted for a poster, acute subtalar fusions for some of these talar neck fractures, especially the ones that have, the bad subtalar dislocation, the ones that are higher risk for AVN. And actually, most of them are done by my partner, all of them done by my partner. But, the thought that they seem to do okay. And in some respects, I think it gives you a little bit more of a stable construct to fix to, because these tend to want to kind of fall into varus anyway. And then, this thought that does it help or does it hurt blood supply? I don't know that's ever been shown one way or the other, at least when I try to look it up. So I'm hoping we can kind of extend out the follow-up a little bit longer on them, but kind of go from there. So the cool thing about this was he's work comp, so he kept coming back. So this is at 3 years. And I'll be honest, I was shocked when he came in with this, because I thought this was going to be exactly like you said, where he was, broken screws and
that looks amazing. I mean, that's a win.
Yeah, huge win. And I'm going to take a second to be a little bit critical, which I think now, after learning more, I think I probably left him a little short on the medial side, and he's probably in a little bit of varus. So I probably could have made him just a little bit longer with my allograft. But at the same point, it's hard not to argue with the way he looks at this point, and the fact that he's got an ankle joint that looks relatively congruent. It does not terribly arthritic and doesn't have AVN. I think is a big win.
Absolutely, right, and it's no infection. So I think that's
and no infection. Win. Yeah. So, and then we haven't even talked about the fact that there was a plate in his tibia on probably a nailable fracture, but maybe that's a talk for the next time. Shoot. All right.